Oh, there we go. Okay. So I want to talk about the top 10 things that are going on in hair today. First of all, I want to give an update. Last year I talked about one of the big things is prostaglandin modulators, and I would say today it's sort of at a standstill. Allergan is doing some research, and it's really, I don't think they're moving forward. I spoke with them about prostaglandin F2, alpha F2, as well as prostaglandin D. So those right now are not a big part of the program. However, one of the biggest things that has changed my practice in the last year is topical finasteride. I use a brand, I don't have any financial affiliation with them to mention it, 82F, which has 0.25% finasteride. And the reason why this is such a big breakthrough is that most men out there don't want to take oral Propecia because of the risk of sexual side effects, and of course, as you probably know on internet, persistent sexual side effects. And so I heard about this last year, started using it, and have gotten tremendous outcomes using topical finasteride. What they do is they titrate the percentage and the tretinoin level so that it has maximal scalp absorption with minimal systemic absorption. And so, like for example, this gentleman on the left is actually on minoxidil and was taking oral Propecia every other day because of side effects and still having side effects. He stopped both, and this product has minoxidil in it, and this is 5 months in after using this product. So I'm actually now starting to look at it, whether it's actually more efficacious than even oral Propecia. I can't state that because I'm still in the early phases of evaluating that, but I'm very, very encouraged with this. The one big caveat is that if you have a pregnant wife, you don't want the, I would just say during that pregnancy is not to have them touch, not to be doing it, because I'm just afraid that the female would touch it and ingest it during that time. Another thing that is huge is compounded minoxidil, which it has a steroid component, a very light steroid component. There's some results in the last few years that show that females have a very high percentage of inflammation that causes female pattern loss. So typical standard minoxidil without this very low dose steroid component may not be as efficacious, and I'm now seeing, for example, the lady on the left was on minoxidil, and we switched her over to compounded version, and she started getting incredible response to it. So this is what's exciting, is that there's so many things that you could do in your practice, even if you're not practicing standard hair restoration. And I will talk about PRP, what my formula is. I have very explicit details, so that there's a recipe for that later in this talk as well. So this is another big thing, and I've been using hyaluronidase in all my FUT or strip cases right after the strip is harvested, and I find that the tension level goes down. I have seen better wound outcomes, and so when you're having a situation where you're either having difficult wound closure or whatever it may be, the wound just in 10 minutes relaxes. So I use a full bottle, 150 units, and about 5 cc's of saline. I just inject it above and below the wound, and it's amazing. And I sometimes will use 2 to 3 bottles, or 2 to 3 times the units I just mentioned, if they have a little bit greater tension on closure, and it just absolutely relaxes the wound. So if you are facial plastic surgeons or dermatologic surgeons and you are looking for ways to potentially reduce the wound tension, I don't know the ramifications. I no longer do facial reconstructive work, but this is to me something that could be very interesting in the context of facial surgery and using it to help reduce wound tension. Another big thing that could be a good adjunct to your practice is scalp micropigmentation. One warning, this is harder than it looks. It is something that can be problematic, but here's a lady that has a scar, and she had SMP into the brow lift scar, and it looks almost as good as a transplant. This is an example of a gentleman that had a previous linear FUT scar that's not so favorable. We shaved his head for a FUE procedure, and then he had a scalp micropigmentation, and the product that we're using now from Italy, I actually can't remember the brand here, I can give it to you later on, is a temporary tattoo that lasts a few years. So this also obviates the fear that you're putting a permanent tattoo in, and allows him to transition during that week where his head is shaved and not have that linear component that's visible to the naked eye on a social professional level. And this is just showing you that in conjunction with either medical therapy, surgery, SMP can really create a very good density to the scalp, and it's a wonderful adjunct if it's done well. But again, I caution you that this is harder than it looks to get good outcomes. And this is why I have partnered, I had an extra slide, I guess I didn't make it to this one. a partner with a really world-renowned artist to come and do very extensive SMP work when I'm looking at balder gentlemen that need a full head with SMP. Another thing that has been controversial in the past is the efficacy of low-level light therapy. The nanometer range is between 630 to 670, and this actually is incredible efficacy. In multi-center studies back in 2013 and 14, Kim et al. And Jimenez et al. Jimenez is the one that had multi-center, blinded evaluation, prospective, randomized, sham device controlled, showed global photographic improvement as well as hair mass index improvement. So I've seen really good results with this. I think that the older generation of products that were office-based, that cost the physician up to $30,000, can't hold a candle to what these newer generations that are very proximal to the scalp, and also compliance. I mean, who's going to drive to the office 2 or 3 times a week? And so this is just, you just wear the laser hat or laser cap for about 20, 30 minutes, about 3 times a week. And you can overstimulate the scalp, so you don't want to be doing this too much. So I think low-level laser therapy is actually a very powerful adjunct. I think it's a little bit more efficacious in women, but at the same time, I think it's very effective in men as well. So you can see this is a gentleman with very good standalone therapy with low-level laser therapy for hair regeneration. As you probably have heard some of the lectures over the last few days, that thicker eyebrows is now in vogue. And so I have a ton of patients that have eyebrow transplants. This is the single hardest thing to do in hair restoration, in my opinion. So a lot of people that come to me and say, hey Sam, I want to learn how to do hair. Can I start with something easy like eyebrows? And I said, this is the most challenging thing that you're ever going to do, and it's going to look ridiculous if you start with this. So when I teach my hair course, I say, if you're wanting to do this, don't start this for 5, 6, 7, 8 years, because you just won't look good with with eyebrow transplants. So this is a lady that had tattoos, and the nice thing is I didn't even remove the tattoos, we just transplant over them. And the great thing is it adds great visual density if it's hidden behind, if the tattoo's hidden behind hair, not in front of it. And you can just see the power, the emotional power of reframing the eyes. It just changes one's life. So it's a powerful thing. Just a little bit more density just changes how the eyes look. So that's really a lot of fun. This is female hair loss is another big trend that I'm seeing, doing a lot more women, progressively more and more, because it's become more socially acceptable. One caveat for those that don't do hair surgery or getting into hair surgery, the biggest thing when I got board certified in hair restoration is understanding that I'm not a dermatologist, I'm a facial plastic surgeon, and I didn't understand all the dermatologic conditions that can cause problems. One of the biggest ones that are coming up today is frontal fibrosing alopecia. And this, when you look for this, there are a lot of signs and symptoms. I'm not going to go through them all, but something that you just need to be cautious of, especially with African American hair losses, may look like traction loss, and it is. This case it was, but you have to, if you have any level of suspicion of what's called FFA or CCCA, get your dermatologist to work with you on a biopsy before you do it. It's so easy to do it beforehand so you don't get burned. This is a chemotherapy problem, and you can get great results in people that have had significant permanent loss from chemotherapy. This is just reframing the shape of the face, where you go from you can see how powerful it is in the rejuvenations. You think about a chin implant framing the lower face, or a facelift framing the lower face, a hairline frames the upper. It balances out the entire rejuvenative arsenal if you have it within your technique profile. And this is another lady that had scarring from surgery as well as chemotherapy, and it's a powerful treatment that you can do to improve the situation. Another big trend that I'm seeing is facial hair transplants, creating a stronger lower face. And this is, again, in many respects, framing aesthetically the lower face. The other techniques you can do are what we've been doing is beard-to-beard transplants, FUE. Obviously, you don't want to do linear strip across the face, and do beard-to-beard transplants to thicken the facial contour down there and create a more masculine profile. And that also can be used for female to male transgender, and transgender is a big part of what is going on today, as you see all over the media. And so this is a MTF, male to female transgender patient, and you can really reframe faces. And this is someone that was sort of not quite transitioning and wanted to be able to have a hairline that would be acceptable in both genders. And so this is just showing an example of something that could be in both directions for this individual. This is a topic that I'm extremely passionate about. If there's anything you can take home, it is bioenhancement technology. What that essentially is PRP, ACell, ATP hypothermosol, which we'll discuss more in detail. I rewrote my textbook in 2015, not because of all the technique changes, which there were quite a few from just 5 years prior, but because of the advent of these technological breakthroughs. And so this is a lady in one session with a transplant that I believe a large part of it, not just through technical excellence, but because of the advent of using all these regenerative techniques, allow one to overcome the limitations of scar tissue in terms of vascular growth. So this adventure started in 2011 when I saw this slide of a colleague of mine, and I said, wow, so PRP was on one side of the scalp and it wasn't on the other. And I started to think this may be a potential. So I started to do a lot more of these, and I started with Autologel. I don't have any financial affiliations with companies, but a lot of people want to know what I use. And had really great outcomes, but I started to figure out, well, maybe I can go even more sophisticated. So I started using the Angel system. This allows me to titrate both quantity and quality of the PRP. And I honestly think you don't necessarily have to have this brand. There's so many good brands out there, but because I'm so heavily involved with hair, I want something that for me is perceived as perhaps the best that I can use. And so traditionally the thought is that you want about a 1.8 to 2.5x concentrated platelet concentration above physiologic levels. Today the thought is maybe 5x. This is a bit voodoo, to be honest with you. There is no real hard prospective randomized controlled studies, and part of the problem is if you do split scalp studies, it bleeds into the other side, and so you don't really get an honest appraisal of what you can see with a 5 or 3x or 2x. So I don't want you to get in love with these numbers, but people ask me this question, so I've got to answer, and I've got to tell you a little bit of the voodoo behind some of it as well. So this is from that particular model of a machine that tells you how to concentrate blood. It doesn't have any bearing for you, but it just tells you how I make some decisions on concentrating it. Platelet poor plasma is the part that you think, okay, this has got to be irrelevant to what you do. I'm going to talk to you about specifically how I use PPP. And part of it, what changed my mind a few years ago, was this slide by Anthony Scalfani that said, hey, PPP, platelet poor plasma, is actually quite energetic and quite beneficial. So I'll talk to you. I use it really in the context of strip surgery and also FUE, but mainly strip surgery, but I don't really use it too much in terms of, just as a standalone procedure, injectable. ACell micromatrix, which is a porcine bladder matrix. There was a great talk, I forgot who gave it a few days ago, that showed that it regrew fingers. It actually creates this, it allows and with an amputated finger, it actually grows out and reformulates the finger. Even the thumbprint. How does it do this? Who knows? I don't know. It's a scaffold technology. And this to me is an integral component to my success with both surgical outcomes with hair as well as standalone non-surgical outcomes. That's my opinion here. So how do I do it? So this is, and for these parts, hopefully it's not against, you're not supposed to take photographs and videos. I am videoing myself, but, and I've had permission for that. If you want to take photographs of these particular slides, you're welcome to do it. This will be on YouTube as well, so you can also review this on my channel. So for surgery, what I do is I do about a 5x concentration with 7% hematocrit. Now, people say you don't want any blood in there, but what I've learned from the scientific head of the company is that having some blood will actually pull in more of the active growth factors in there. Again, some of this is a bit voodoo, as I said, but I think that actually can help enhance results by having the 7% hematocrit. So I take 120 cc's of raw blood, spin it down, and then I get what you see below. I put about 5 cc's of platelet poor plasma into the donor area after closure. Honestly, I don't know if that makes a huge impact. To me, the biggest thing is a good donor harvest and good donor closure, and use of hyaluronidase. And by the way, also I leave my sutures in now for FUT for 15 days. It's made a big difference in the scar outcome. So if you can have your patients leave it in even longer, is great, but somewhere in that 15-day range, and I used to do 10 days, I'm seeing even improved outcomes. So 15, and I'm going to go more into detail about the next line about the 15 cc's of PPP. That's going to be in a more detailed slide. But I actually take that that strip that I remove and put it right into physiologic PPP at room temperature instead of chilling it. I think it reduces shock. I learned this from an Indian colleague who presented on this a couple years ago at the ICHRS meeting, and I think it has made a difference in the way that my survival is for my grafts. And then I place now, after I've created all the recipient sites, I then inject about 9 cc's, 10 cc's of the PRP and ACell mixture. It's 100 milligrams of that, shaken up and placed injected subcutaneously. People ask me what depth. I don't think you can really control the depth. And definitely if you're doing it after site creation, wear goggles so you don't splash blood into your eyes. And then I coat all the grafts right before placement. There's a question people have asked me, does that affect the ease of placement? I haven't seen that. It's really, I don't think it affects that at all. Without surgery, this is something for most of the people out here who don't do surgery. I have about a 3x, and it depends. Honestly, if it's a smaller area, I may have variable concentration. Again, you're welcome to take any photographs of these if you like. And I concentrate down depending on the area that I'm doing. I may use 15 cc's, 30 cc's, so between a 3 and 5x concentration. And I use a lot more ACell. So I use 200 milligrams of the matrix-stem, so 2 of these fine powder boxes. They come in strips and various other things. I use the fine powder one. And then I inject it in, and I use a nano pen or micro pen, and I sit there for 10 minutes and I really stimulate it. To me, a huge component of my success of being able to do this with one single treatment, not repeated 6 series, but a single treatment, is using the micropen technology to try to get this stimulated and using enough ACell. I think the ACell adds so much to the total outcome that I believe that PRP by itself does work, it absolutely works, but I think a large part is the activation and the ACell. If you don't use ACell, I would encourage you to activate it. What I try to do is sometimes if you over-activate it, you can create too much irritation to the scalp. I usually have my staff, I sort of quadrant out the areas I'm working on. I time it, so I use about a minute to 90 seconds per quadrant of the areas I'm working on, and that just allows me to time the amount of, and usually that gives me the sunburn look that I'm striving to achieve. And some of my colleagues also, just talking to them, have found great success with a single treatment. And another colleague of mine out of Atlanta actually looked at a series of doing 6, 5, 3, 2, and 1. He said he's getting very similar outcomes, almost the same. So I encourage you to think about using higher quality and rather doing multiple sessions. So, obviously if you're doing great results with 6, that's fine. I mean 6 sessions. So activation is key. Activating it, not just putting the PRP in. I personally believe that chemical activation is insufficient. Thrombin or calcium gluconate, it just doesn't work as well as mechanical activation. And these are just some result where the first result is in the middle is without the PRP. This was in ACell. This was back before around 2011. I did a second session with him and it's like, oh my God. And same thing here, the middle session, it's hard to see in this. When I looked at it, I wasn't impressed. I came back, did a second session with the PRP and ACell. Oh my God. So these patients served as their own controls. And the same thing here. I just started seeing incredible growth. So that changed everything. Liposomal ATP is a huge part. The way that this works is that it actually stabilizes the sodium potassium ATP pump. So it minimizes the ex vivo damage to the grafts. I added this in about 2014 and with hypothermosol, which is a storage medium, and I'm seeing incredible improvements in growth, speed of growth, finer grafts. I believe that even the insertion of grafts by the most experienced placers can cause some micro trauma. So I'm seeing even more improved grafts. A colleague of mine actually, it was pretty interesting, he did it on one side in a radiated bed. He took these grafts, stuck it in a refrigerator for 2 weeks, and then placed the grafts back in after it's being stored in refrigerated hypothermosol liposomal ATP. And on the other side, he had immediately ex vivo dissected and placed back in, but stored in saline, into non-irradiated tissue, and he found significantly higher growth in the irradiated side with grafts sitting for 2 weeks in a refrigerator. So this is why sometimes if I'm doing an extensive case, I may harvest a beard the night before, I may make recipient sites and then store those beard grafts for the next day and then do the strip if I'm doing a big case, because I know that the graft take can be so high, even with extended ex vivo time of these grafts. So again, I have no financial affiliation with any of these companies. They don't pay me to say any of these things. But to me, this is the 4 quadrants of what I do to make results so much better. the bottom line is if you don't do good surgery, none of these things work. But if you do good surgery, this can make a big difference. A colleague of mine out of Brazil looked at something called a personal growth index, where he measured hair mass indexes because he does long hair, so he can actually long hair transplants, so he can actually measure the thickness immediately before and 7 months later. He found that patients can be their own limiting factor, even if you go to the best surgeon. So if they grow 70%, every time they could grow 70%. And so this, to me, blows out the concept of PGI and allows for higher growth potentials in patients. So this is a confusing slide. You can take a photo of this if you like. This is how I do it. You're welcome to come and ask me about this. It's in the book I wrote anyways with this. I make no money on my books or courses. So I take 50 cc's of ATP, I split it into two, and I take 10 cc's of it, I mix it with 100 cc's of hypothermosol for slivering and dissected grafts. I take the remaining 40 cc's of ATP and 400 cc's of plasma light, and I use some of it to spray the area, and the rest of the 100 cc mixtures, the patient sprays their scalp every hour for the first few days, except when they're asleep. If they can wake up at the first day, is great. But to me, that's a huge component in helping the grafts like CPR to survive. So how I do it on the bottom is I take the donor strip out, if I'm doing FUT, place it in 15 cc's of physiologic PPP, then I transfer them into this ATP hypothermosol, and then right before placement, I use PRP and ACell. So these are highly coddled grafts, and they make a big difference. I don't believe right now we have enough knowledge about stem cells, but at the same time, I think this is an interesting concept of injecting fat or other things in the scalps. But this is very early in the process. This is just showing some examples of what PRP ACell. And you can see that even after Propecia, it adds another level. So these, to me, are synergistic. They're not redundant. And for females, it can really improve one's results as well. And this is just as a standalone technique. So don't forget this, okay? It's all mentioned in my first volume of the book. So FUE is the last topic. Everyone wants to know about it, and I'm going to briefly summarize how I think about it. And it's so romanticized. All the marketing on the internet that you're going to see these ugly scars if you do a strip scares the dickens out of patients, and I think this is a travesty to scare patients, because you can get beautiful scars if you do the right thing. And you can also get horrible FUE scars. I've seen so many over-harvested, moth-eaten, destructive scars that I can't fix this. I can fix a strip scar. I can't fix this. You know, so this is something that people sell as scarless. I think that's a shame. It's so important to be out of this hype loop and to really see both sides of the picture. What are those two sides? Well, it's just a harvesting technique. It's only as good as what your tools are and how good you are as a surgeon. And the result is, to me, is critical. So don't just sell the technique, sell the result. What is safe? So the safe donor area, because if you think about it, it starts to encroach over time. So what that is essentially is that it's the area where that patients, if they are harvested from, can potentially over time lose those transplant grafts. So people that do hair now with these technicians that fly in have really no clue what the heck SDA or safe donor area is. I think the problem is that you are the surgeon. You have to understand this. You have to really understand what all this is. And so for maximal harvesting, you can combine FUE and FUT and get outstanding outcomes. And I oftentimes don't combine at the same time. I always think I want to save something in the bank. Don't burn out all that donor hair. Save it for the future. Don't just get a wow result. I see this stuff on social media, a wow result, and they have nothing left at 40. And this is a crime. You know, I think that you need to be very, very honoring of the donor area. So that's important, not just to burn it out. So how do I use FUE, FUT? This is an unvarnished, honest comment. This is not some marketing thing that's just going to be thrown out at you. I want you to really be thoughtful surgeons. So FUE grafts have traditionally been very, very flimsy. And so the problem with FUE is that they don't survive well. The great thing is the new technology of harvesting techniques. For example, this WOW instrument is a great instrument. It's allowing to get closer and closer to strip graft qualities. And today where harvesting technology is moving toward is a hybrid where it's no longer just a sharp punch, which may have a higher transection rate, or a blunt one that may cause more frictional injury and buried grafts. It is this combination of a sharp and blunt. And that's, if you don't go to the hair meetings, that's really where that's really where we're moving toward is higher quality grafts. At the same time, the honest truth is FUE uses more potential donor capacity in the back of the scalp than a linear strip. The reason why is to avoid that moth-eaten appearance. You can't go out there and harvest 50, 60, 70% of the donor area. Some people with bad shingle of hair, in other words, if the hair sticks out like this and you can see the scars more, can only get up to maybe 15 to 20% of total scalp area back there, whereas in a small little strip, if I take it out, I have a lot more potential for transplantation. So always think about how much total donor capacity and marry that against the patient's age, the degree of donor loss, the degree of the degree of recipient loss, and how much donor density that person has. So I love FUE for limited hair loss. I think it's great. And it preserves the donor for the future, allows me to stay closer into the saved donor area. But I think that when you're seeing a gentleman that has extensive baldness, that is really super bald, that says, hey, Dr. Lamb, I saw this stuff on the internet, there's no way I'm gonna do a strip. Okay, fine, you can do an FUE. But if I'm gonna try to cover that whole scalp in a single session with FUE, it's extremely hard, and I burn out a lot of donor hair to get it done. So I try to educate patients that this is not a dinosaur of a procedure. It's an incredible procedure that allows you in the right hands to create great results with minimal donor scarring. Of course, you may not be able to wear your hair as tightly shaved as I can, but if I can get you almost a whole head of hair, do you care? A lot of people wear their hair short because it's the only option they have. So when I see a gentleman like this, I personally, you're going to hear this unvarnished, to me it's laughable to try to do this with FUE. This is a strip case for me. I want to cover his whole head. And if he only wants FUE, I'll do the FUE, but there's no way I'm going to try to get his whole head covered with it. I think it's insane. And so this is an FUE case that, obviously it's just a model, but I'm just saying really closely shaven scalps with minimal loss, that's great for FUE. You can use FUE in a lot of creative ways to fix donor scars. Okay, you can do beard FUE to correct this guy that has no more donor hair left. It's not a great result. It's not 100% natural, but at least he can go out without a hat. And so it allows you those capacities. This is a FUE case. It's, limited loss, allows you to get great results in the select patients. So, if you just try to do FUE on every patient because that's the only thing you know, I personally, being a hair surgeon, think that you're really only doing half what's out there and you're forcing everyone into one category because that's all you know how to do. This is a gentleman that had a strip FUT to fix bad transplant with beard FUE to get enough donor capacity to repair this pluggy, weird looking hairline and loss of central density. So this whole saying is that this, if all you have is a hammer, the whole world looks like a nail to you. So really be surgeons out there. Don't delegate this out to someone else. Understand this. And this is, again, I make no money on the books that I write. Everything goes to charity to stop international sex trafficking, which is a passion of mine to stop this injustice in the world. Just so you know that. This is a 4-volume series. And then I really encourage you to come to this course. I give up my honorarium so that I can say this so that you don't think I'm trying to make $1 on this, and I don't make money on this, but I love my course. It's August 3rd to 5th. People that have taken it have loved it because I personally believe that what's important is to really love this. A lot of my facial plastic surgery colleagues look at hair as boring and stupid, and I get incredible joy. If you don't get incredible joy in what you do on a daily basis, don't get into this field. Don't do hair just to make another profit and to make another $1. It's so creative and fun, and I'm hoping that if you spend those 3 days with me, you're going to really see the creativity and how fun it can be. It really is enjoyable, and the really bottom line with this is that you can sit and listen to me lecture for 10 hours, and you're going to absorb this much. But when I watch your hands, when I watch you operate, even if you're the best facelift surgeon in the world, and I've had those in my course, that I see all the errors when they're working on recipient site creation hairline designs. It takes a lot of years to get there, and I give them tools. And within a few minutes to an hour, I watch them, they're better. And then in 2 hours, they're better. The next day, they're better. And the next day, they're better. And then I give them tools to go home and work. So I encourage you all to have the vision for what you want in life, personal life, professional life, everything in life. And really, deep down, have passion for where you want to be. Okay? That's it. Thank you.